It depends because there are several types of major neurocognitive disorders, which I will talk about in the next few slides, and they each present with different cognitive deficits. So as you can see in this slide, we have at least 16 known types of major neurocognitive disorders. The most common one is Alzheimer's disease, but you should also know about the other ones and be aware that there is a longer list of differentials when it comes to cognitive decline, especially in older adults. So I realize it's a lengthy list, 16 types is a little bit too long, but we can go through them bit by bit. For now, I'm gonna go through the most common type of major neurocognitive disorders or dementia, which is Alzheimer's disease. So how do we describe Alzheimer's? It's a slowly progressive neurodegenerative tauopathy that leads to brain cell death, causing impairment in functioning and cognition, ultimately leading to death. It is most commonly occurring after age of 65, with the incidence rate doubling every 5 years after 65. The most common early symptom is short-term memory loss, followed by visuospatial problems, language difficulties, and disorientation. Behavioral changes are quite common, and it's also characterized in later stages by loss of bodily functions, ultimately leading to death. The staging is very similar to what we had discussed in previous slides. It comprises around 70% of cases of dementia worldwide, and the numbers, as we had mentioned before, are expected to triple by 2050. So the etiology of Alzheimer's disease is different depending on what type of Alzheimer's disease we're talking about. When we're talking about early onset Alzheimer's disease, where the onset of illness starts before 65, and that only comprises around 1 to 2% of all cases with Alzheimer's disease, it's mostly familial with an autosomal dominant inheritance, meaning that each generation in the pedigree will have at least one case affected by the disease. It is characterized by a much rapid progression, and there are some identified gene mutations leading to such a disease, like the amyloid precursor protein gene, the presenilin genes, and a high inheritance of the ApoE4 allele inheritance. Most will increase the load of the amyloid beta protein, which is responsible for formation of the toxic amyloid plaques that impairs neuronal function, leading eventually to neuronal cell death. There are other implicated genes in the early onset Alzheimer's disease, including the ABCA7 and the SORL1 gene. So the other type of Alzheimer's disease is the late onset Alzheimer's disease, which is mostly sporadic, not inherited. It starts after the age of 65, and the strongest genetic risk factor is having the ApoE4 defective allele. We have different types of ApoE alleles ranging from 1, 2, 3, and 4, and the ApoE gene is responsible for encoding a protein that should remove toxic amyloid from the brain. It has been discovered that the ApoE4 allele encodes a defective protein, causing a much faster accumulation of toxic amyloid in the brain, which we believe so far is the main culprit causing Alzheimer's disease pathology. So if you have one copy and you're heterozygous for the ApoE4 allele, you have 3 times the risk of developing Alzheimer's disease. But if you're homozygous for the ApoE4 allele, the risk increases to 15 times the general population. Non-genetic risk factors that causes late onset Alzheimer's disease include head injury, clinical depression, high blood pressure, diabetes, hypercholesterolemia, smoking in early life, air pollution, biometals in toxic doses, and there are some studies now examining if sleep disturbances in middle age puts you at a measurable risk to develop Alzheimer's later in life. So allow me to go quickly over the pathology of Alzheimer's disease and how it progresses. So first we'll talk about the amyloid plaques, which begins with the amyloid precursor protein, which creates a much needed transmembrane protein that is important in neuronal development, but it gets broken down by an enzyme called beta secretase and gamma secretase, creating amyloid beta peptides that are partially soluble. But if you have mutation in those genes, the amyloid precursor protein or the present genes, you create abnormally long proteins, which are less soluble than the regular healthy amyloid beta peptides. These insoluble, abnormal, long peptides create oligomers that make plaques, and these plaques are quite neurotoxic because they activate local microglial inflammation, increasing a lot of oxidative damage, tau phosphorylation and dysfunction, and calcium-mediated excitotoxicity, leading to neuronal cell death and apoptosis. So these amyloid plaques cause neuronal dysfunction because the hyperphosphorylation of the tau protein, which is a much needed protein inside the cell that helps the cytoskeleton transporting chemicals and neurotransmitters up and down the neuron, starts dissociating from the cytoskeleton, and the cytoskeleton cannot function as it's supposed to. And these are called the neurofibrillary tangles. They are basically made of hyperphosphorylated, unhealthy tau proteins. So that was talking about the microscopic aspect. When it comes to the macroscopic aspect, which we could see on brain scans like a PET scan, an MRI scan, we typically see atrophy in certain regions like the temporal cortex, especially the hippocampus, which is responsible for memory loss. The parietal cortex follows, which is responsible for the special sense praxis and some language issues. The frontal cortex, which in turn affects attention and executive functions, some of the emotions, and then the cingulate gyrus, which is responsible for motivation, and the locus cerealis in the pons will affect the mood, vegetative functions, and the level of alertness. So how do we diagnose Alzheimer's disease?